screening is critical because there is a large burden of colon cancer which is preventable in this country. Prime candidates for a colonoscopy would be anybody who reaches the age of 50, irrespective of their background or their family risk profile. Folks who have had relatives, first-degree relatives, parents or siblings with colorectal polyps or colorectal cancer are eligible to have colonoscopy at an earlier age, say 5 or 10 years prior to the usual recommended age, which is age 50. Patients with risk factors, certainly the most important group would be patients who have symptoms, alarming symptoms, such as a change in bowel habit, bleeding from the colon, or weight loss. These are some of the major alarm symptoms that we focus on when recommending a colonoscopy. The preparation begins about 3 days in advance of the colonoscopy, and the earlier portion of the prep involves some dietary changes, such as removing heavily fibrous foods from your diet. The night before the prep is usually the most fearsome for patients because it involves drinking a solution, which is a purgative, which can involve cramping and obviously diarrhea and a certain amount of discomfort. And the prep can last anywhere from a couple of hours to all night long. When the patient has taken the prep the night before, they come to their appointment for the colonoscopy the next day. Generally speaking, the procedure is done sedated. They arrive about half an hour before the procedure. They do a brief intake history and physical, and then we begin the process of sedation and finally the colonoscopy. The colonoscopy generally takes about 20 minutes to complete. During that procedure, we can do a variety of interventions, such as removing polyps. In certain cases, we can stem bleeding under certain emergency circumstances, but in general, we can not only see diagnoses, but we can remove pathology at the time. If we find a precancerous polyp, that eliminates any possibility that cancer will arise in that spot in the future. Typically after about an hour, they will start to wake up from the anesthesia and they will be readied by the staff to go home. They will have to have a driver to take them home from the procedure because they may still be a little bit sleepy. They can expect to eat a regular diet for the rest of the day. The only requirement we have is that they not drive on the day of the procedure. So they are back to their usual activities and work the next day. Generally speaking, at the time of the colonoscopy, I can reassure the patient that we have a non-precancerous or a precancerous polyp that's been completely removed. We send those specimens off to the pathologist. They get examined under the microscope, and typically the patient will receive a letter from me in about a week to 2 weeks after the procedure with the results of their pathology and a recommendation for the interval at which we next recommend a colonoscopy. We aim to prevent formation of colon cancer by detecting polyps earlier, whether it's somebody who has the genetic trait or somebody who has absolutely no genetic potential for forming polyps.